All right. Good morning, everyone. This meeting's called to order. Today's meeting is going to be hybrid, as well as the meetings going forward. And Healthcare Authority staff will be on site. Board members and other attendees have the option of attending on site or via Zoom. For our Zoom attendees, our opening slides has information about how attendees can turn on the closed captioning. Board member introductions. We're going to do roll call. Terry? Oh, let me take a look at my list here. Terry may come. Is Terry with us? Terry House?
No, she's not.
Okay. Myra Johnson?
Present.
Allison will be out. Donna Hanson-Murray?
Hello, good morning.
Pamela Cruz?
Good morning. May the 4th be with you.
There we go. Very nice. Amy Griffin?
Good morning.
And Carrie Schaefer.
Good morning.
Morning, Carrie. And here we also have our AGO rep, Katie. And I'm Lou McDermott. I'm the deputy here at HCA and the SEB chair. With board members both in person and virtually, which is not correct. Well, I am a board member, so technically yes. It would be helpful for the board to hold their questions until each presentation is done or when the presenter pauses and asks if there are questions. Board members attending virtually, also we will be watching in case your Zoom hand goes up to indicate that you have a question. And the public's going to have an opportunity to provide general comments at the end of the meeting during the public comment period. Jean Bowie, the Deputy Director of SEBB, is filling in for Dave today and will be providing an overview of the agenda. Welcome, Jean.
Thank you, and good morning, Chair McDermott and members of the board. For the record, my name is Jean Bowie, and I am the SEBB Deputy Director. On today's agenda, Cade Walker will be back with a final wrap-up of bills that made it through this legislative session and that impact the SEB and PEB programs. Tanya Duell will be back with an overview of the final budget. And Janice McAlpin and Sarah Whitley will be presenting on House Bill 1222 that Cade has been keeping you apprised of this session. Janice will be teeing up a resolution on the hearing instruments for the Uniform Medical Plan, and this bill is currently at the governor's office for signature. I also wanted to make sure that board members received the email from Dave about HCA's rescheduling of the Benefits 24/7 launch from next week to June 12th. This will give HCA more time for testing the data migration into the new system, will help payroll and benefits office staff to review training materials and consult with HCA staff with questions, and to finalize access approval to Benefits 24/7 from SEB and PEB appointing authorities. We've been notifying members of the new launch date on the SEB and PEB web pages and with upcoming member mailings. Okay, back to you.
All right. Any questions from the board? All right. Our first agenda item is approval of meeting minutes. Today we're going to be voting on 2 sets of meeting minutes from this board season. There will be a vote for each set of minutes. Minutes are behind tab number 3 and separated by goldenrod sheets of paper. Our vote is on the January 26, 2023 retreat meeting minutes. Are there any comments from the board? Do I have a motion to approve as written?
Pam Cruz, I move to approve the minutes as presented.
Is there a second?
Donna Hanson, I second it.
All right. All in favor, say aye.
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 Any opposed? Hearing none, January retreat minutes are approved as written. Next vote is on the April 6, 2023 meeting minutes. Any comments from the board? Do I have a motion to approve the minutes as written?
Pam Cruz, I move to approve the minutes as written.
Is there a second?
Donna Hanson, I second that motion.
All right. All in favor, say aye.
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 Aye. Any opposed? All right. April 6, 2023 minutes are approved as written. Thank you. Next agenda item is legislative season debrief. Cade Walker, the Policy Rules and Compliance Section Manager in the SEBB Division, is going to share updates on the bills that passed in the 2023 legislative session. And
just wanted to make sure that my audio is coming through just fine, sure.
Audio's coming through, and for board members, the material is behind tab number 4.
Perfect. All right. Well, thank you, Chair and members of the board. Happy to be with you again to give you the final debrief from the legislative session. Just as a note, I usually like to be there in person, but I am in Spokane getting ready to present a few sessions at the WASBO conference. So if anyone's listening is in Spokane for the conference, love to say hi and happy to chat more about either lunch stuff or you might have to get something running to the WASBO.
Kate,
I'll turn it on now. Yes?
can you also mention the special session and whether or not it has any impact on SEB? Because there is a special session coming, I think, May 16th
Correct.
or something like that. So
Yeah.
just include that in your comments.
Yeah, well, that's, I'll go there right now. That so the session did conclude, the regular session did conclude, but we will be having a special session that the governor called, I think just yesterday, on the 16th, regarding legislation around penalties for drugs, possession and use, something along those lines. Nothing that I'm aware of that has an impact on SEB or PEB. But it does, I think there is probably, and Lou probably know better than I would, there'll be some impacts potentially on the Department of Behavioral Health and Recovery, maybe some other impacts of the agency, but none that has been articulated so far to our program, as far as I'm concerned. But with that, I'll go ahead and give a debrief of the regular session that concluded a couple weeks ago. And so I'll go ahead to the next slide, please. Here's our final tally of bill analyses that we performed for the year. We had a good number of ERB high priority bills this year, more than typical for us, but that made for an interesting session and an exciting session for us. A lot of fiscal notes. Fortunately, that didn't change too much in the latter part of the session, but we did have a pretty significant number of fiscal notes, but not a huge number of a wide swath of bills to do in the first place. So our team did a great job, as always. Our 25 plus analysts coordinating amongst the agency, working to get their bill analyses done, fiscal notes done. So again, I want to make sure I give a big shout out to all of those in the division who support us in the bill analysis efforts. Next slide, please. Here's our funnel of the, I want to say about 30 or so bills that we were tracking that were ERB-led priority bills. We did see 12 of them cross the finish line and have either been signed by the governor or sitting on the desk for signature currently. The rest of the bills that are stuck in the funnel all the way up until the opposite rules floor, those will all be active again for next session, assuming they get reintroduced by rule. We have a long session that we just finished. Next session will be a short session that concludes this legislative the legislative term, the 2-year term. Next slide, please. So we go through numerically on the legislation that passed that was a high priority for the division. These are bills that would have much more direct impacts on the division as opposed to some legislation that we track, and we're just making sure that the iteration that we did review doesn't change and then have an impact. So these ones are what passed of the 12. They had high priority. So starting with 1008, and I think a lot of these I've already talked about, so I'll try and be fairly brief with them. 1008, this is expanding the definition of Plan 2 members into the separated employee definition. So that the Plan 2 members, when they separate from state employee, they've met the year's requirements, but they're not going to draw on their pension yet. They can start participating early in retiree coverage, similar to what Plan 3 members are able to do currently. Then we have 1222 that Janice will go over more, expanding the hearing aid coverage for all commercial insurances. Then we have 1357. I will go into a little bit more detail on that one in another slide because of some questions that came up on that, and went through a lot of different iterations. So I've got a slide on that in just a moment. Then we had House Bill 1804. This is the legislation that helped to address an issue that was discovered when employer groups leave the PEB coverage. They are in PEB on a voluntary basis, and they decide to leave that coverage. the retirees and disabled employees that they have on our retiree coverage would be kicked off, and oftentimes they don't have any other coverage. So this allows them to remain in PEB as a retiree and pay the full, an unsubsidized rate they would pay. There's a couple different nuances in there. I don't think it's terribly germane to get into, but we are currently working on implementing that. Then we have 5242, eliminating cost sharing for abortion services. 5275, creating the ability for certain groups to join the SEB program as an employer group. And those specific organizations include tribal schools and associations that represent school employees, as well as the board members for school district boards are eligible now to participate in SEB. Next slide, please. 5300, regarding the pharmaceutical continuity, continuing pharmaceutical coverage for behavioral health services and pharmaceuticals. 5396, reducing or eliminating the cost sharing for breast exam services. 5421, this is the legislation that we helped draft regarding protecting the enrollment information for all PEB and SEB program data that we collect, creating an exemption in the Public Records Act. 5490, this is the, usually we would refer to those like this as a second bite at the apple, but this one had such a very narrow definition that we call it a nibble at the apple, that it provides for a very narrow population of retirees who missed out on eligibility for PEB retiree coverage to come back and rejoin PEB retiree coverage under very limited circumstances. The 5700 was the agency cleanup piece of legislation, just cleaning up our definitions and making sure all the different sections of statute that have been consolidated over the last couple of years were nice and cleaned up and modernizing some language as well. Then last, the 5729, extending the $35 per 30-month supply of insulin legislation. With that, I want to just pause and see if there's any questions about the high priority legislation that has passed so far. For this passed.
We see any hands up?
We're not seeing any hands, Kate.
Great. All right. Next slide, please. So a little bit more information about 1357 for those who are interested. This is regarding prior authorizations and amending the prior, having some requirements for prior authorizations for commercial insurers. So there's a few different time frames in that. There's requirements for the time frame for decisions to be truncated or to be streamlined. So when prior authorizations are submitted, they now have a time frame that's been set up by a statute. That goes into effect at the start of next year. There's also electronic authorization standards, meaning that the prior authorizations that are done through an online system, setting up certain requirements and standards. If things are approved at a certain rate, then they need to be just approved without having to go through as much of a rigorous process. That goes into effect at the start of 2025. And then last is there's additional communication requirements that carriers will have in both general information about prior authorization as well as specific information when prior authorizations are being submitted by members. That also goes into effect at the start of next year. So a lot of work on our carriers to be updating the process for prior authorizations. I think it's very consumer friendly. It will be very good for the members to have these new expedited and streamlined ways for them to get prior authorization for services or pharmaceuticals. So you can see here, it also, not only does it apply to private health insurance, it was in the legislation very specifically called out to apply to both the PEB and SEB program carriers, as well as to Apple Health or the Medicaid program. Next slide, please. We'll go through a few of the different provider types that have had adjustments made to either the certification allowances that they're allowed to have, services that they're able to provide, or their new certification that we now have. So the Mental Health Counselor Compact, legislation that allows for multi-states who participate in the compact to have their mental health counselor certifications be shared between the states that participate in that compact. And I think currently there is Idaho and Oregon participating, so mental health counselors in those areas are able to provide services to members in the state of Washington and vice versa. 1073 medical assistants, they have services that they are now able to provide that are in addition to what they're currently permitted. Dental hygienists, the same thing, expanded scope of services they're able to provide as under their certification from the state. 1576 dentist compact, similar to the mental health compact. In fact, I think there's a nurse compact as well that was signed. It's in the next slide. So a few of these compacts, multi-state compacts, allowing for the certification of providers in one state that participate in the compact to be recognized in the other state. Certainly be able to help with some of the provider shortages. 1678 dental therapists. This is creation or expansion of use of dental therapists and very useful in rural areas, as are denturists. That also saw expanding scope of services they're able to provide. Next slide, please. Then we have the new certification, other behavioral health support specialists. These are additional service providers in behavioral health. I'm not terribly familiar on what differentiates them from other behavioral health support services that providers, but there's an effort now to have different levels of providers that can be certified by the state, and behavioral health support specialists are one of those, as well as 55 certified peer specialists, a similar behavioral health support certification that the state will now be providing. Home care aides certification is a new certification in the state to certify home care aides that provide services. Optometrists saw some expansion in their services they're able to provide, and I already mentioned the multi-state nurse licensure compact, expanding the ability for nurses to have a license that they can practice in multiple states. So I think all very good, seeing the expansion of provider types and the services they can provide. It's helpful for our members. We don't put those as high priority. For the new certifications, they won't have immediate impact on our programs because they're not necessarily required to be covered at this point. But it is something that we would track and see in the years to follow that those services are likely to make their way into covered services that our carriers provide coverage for. Next slide, please. A few of the new expanded services or modified services that are offered. New services now being required and provided for by commercial insurance is intramuscular needling. I'm not sure I want to look into that too much. It sounds a little terrifying to me, but to the extent that there is a therapeutic value in intramuscular needling, still just kind of gets under my skin a little bit. That is now a required commercial service. There was expansion in telemedicine requirements and further safety protections provided in 5036, as well as some amending language to the Death with Dignity Act, and expansion on required maternal supports for pre and postpartum supports for individuals. Next slide, please. All right, so with that, on some of the high priority pieces of legislation, we did have some of them that have immediate implementation or have immediate effective dates. So that there was emergency clauses attached to several of our pieces of legislation that we have a lot of administrative work that we had to hop on immediately. So I want to just give a brief overview of the work that's being done to implement legislation that passed that has administrative impacts on our program. And these have both impacts kind of in the SEB and PEB program. I'm sharing all of it. It's a little too messy to try and parse it out, especially because some of them are actually too illegal. So as noted, 1008 expanding the definition, 1804 expanding the definition of separated employee to now include Plan 2. That goes into effect at the start of next year. Then we have 1804 regarding the closing the gap or mitigating the issue for retirees when their employer leaves. That went into effect immediately. Now there's three components of that, and I'll talk about those in a second. There's three components to that legislation. One of them that has an immediate impact to allow retirees who lost coverage when their employees left to come back, that we're currently working on and the process for that. 5275, this is the SEB employer groups, tribal schools, associations that represent school employees, and the members of school boards. That goes into effect. Really, the start of it is they're able to start coverage in 2024, but we know that the process of getting their employees all switched over happens a few months before that. So we've stated it as a 9/1 effective date because we need to make sure our processes and application contracts are all squared away for them to be able to start the coverage effective 1/1 of 24. And then last, 5490, the nibble at the apple for some retirees that had an immediate effective date, and so we've been working on getting that implemented as well. Next slide, please. Just a bit more details about what we're doing. 1804 and 5490, this is where there's at least two separate and distinct populations who now have the ability to come back to retiree coverage. It's a pretty narrow population. For 1804, that population would be any retiree who's separated, retired from state service, has a qualifying pension, that attempted to come back to retiree coverage, were denied because they failed to defer that coverage. Then they appealed that denial and still lost that appeal, and they have to be Medicare eligible. So if a retiree meets those criteria, they're eligible to return to retiree coverage, as if they had deferred and maintained credible coverage and everything. They're able to return. They are limited to the plans they're eligible to enroll in. They're only permitted to enroll in a Medicare supplement or a Medicare Advantage plan. They're not permitted to enroll in a classic Medicare plan per the statute. Then 5490, again, the narrow population of retirees. So all of this, we're working to identify those populations. It's a little tricky because 5490, we have a little bit of an idea of who they are, same with 1804, but trying to track them down now, years after they may have had impacts or been denied returning to coverage. We're working to identify them so we can reach out to them directly. We're also underway with emergency rule writing, and it's a little different for our team to do some emergency rule writing as opposed to our regular rule writing process that starts in January and is submitted to the code reviser in May. These emergency rules operate a little differently. There's no external review with them, and they expire after 120 days, but it's something that we need to have, so we have a process in place to be able to have these retirees come back into coverage and to make sure that all of our ducks in a row process-wise. We are working on a communication plan. So not only are we trying to directly identify and reach out to potentially eligible retirees, but we're going to have other efforts going out with different organizations that work with retirees and having a little bit broader message sent out. We're trying to be cautious with sending out too broad a message because we don't want to create a sense that there's a wide open opportunity for individuals to return to coverage, only to come to the healthcare authority and discover that they are actually not eligible. And so we don't want to be turning away a lot of people and giving some false sense that this is an open door opportunity for retirees. So we're trying to make sure that we balance that line between communicating effectively and trying to find all the individuals who are potentially eligible, but also not having the floodgate open and have our call center bombarded with calls and a lot of denials that would be sent or given to individuals who don't meet the criteria. The processes for re-enrollment and payments are being set up. Our accounts receivable team are doing a great job making sure that we've got all our ducks in a row there, as well as our training our staff on the process and the questions that we have. And I was just reviewing earlier today the website page that we have for this. So we'll provide some. I'll make sure to provide some updates at a future board meeting about this. But needless to say, we're moving quickly to try and get this all implemented so that the retirees can return and start their coverage back up again. Next slide, please. So for the other two pieces of legislation that we're working currently on implementing, for 1008, it is primarily and almost entirely an emergency rule writing implementation effort where we're changing up those definitions and making sure that our forms and other things are take into consideration this expanded definition of separated employee. And those, it says the implementation of 100 goes into effect at the start of next year. So we'll have emergency rules in place, and then we'll begin permanent rule writing in the regular session that we do starting in January. Then last, 5275 for the SEBB employer groups. It's going to mirror very closely the process on the PEP side, which has had employer groups for a few decades now, at least a couple of decades. So that's nice that we've got a template already that we'll be mirroring for the SEB side, as well as having emergency rules so that the employer groups can join for the start of 1/1/24. Then we'll have permanent rules that will get in place next year in our normal cycle. Next slide, please. That's it. All right, that's it for me. Is there any questions about session or legislation that we're currently working on implementing?
Any questions from the board? We're not seeing any, Kate. Very much appreciate it.
Thank you very much.
Yep.
Thank you, everyone.
Next agenda item is the 23-25 biennial budget update from Tanya Dool, our finance manager from Fiscal Services Division. She's going to provide an update on the biennial budget, and keep in mind the governor hasn't signed the budget yet, so it's not been enacted into law.
All right, good morning, Chair McDermott, members of the board. For the record, my name is Tanya Dool. I am the ERB Finance Section Manager, and I'm here to give you a quick update on the final conference budget. Next slide. So up first are the final funding rates for the upcoming school years. So we're looking at for school year 2023-24, $1,100, and then school year 24-25, $1,157. Both of these amounts are paid to HCA per eligible employee per month. They are also adequate to maintain our current level of benefits, as well as fund the upcoming decision packages I will walk through on the next slide, which include the additional investment that was included in the healthcare agreement for collective bargaining agreement, the collective bargaining agreement that was negotiated this summer. So on the next slide, these should look very familiar, as all four of these items were included in the governor, the House, and the Senate proposed budgets. So here in our final conference budget funding, first up we have $11.1 million. This is for our self-insured third-party administrator, so our TPA. This is Regents, Moda, Delta Dental for our self-insured medical and dental offerings. As we receive increased enrollment in those plans or changes in the enrollment in the self-insured plans, we do adjust our funding to be able to pay our third-party administrator fees. This is something you'll see from me probably every budget. Next up is the UMP Diabetes Management Program. This is an app-based intervention that will be available to members with a diabetes diagnosis who meet certain criteria starting with plan year 2024. So the funding you see here is for 18 months of the upcoming biennium. This is different than our current program, which we have a diabetes prevention program offered. So this will be a management program for those who meet certain criteria with a diabetes diagnosis. Next up, we have a vision enhancement. So starting with plan year 2025, we will enhance the hardware benefit from $150 to $200 every 2 years. The amount here of $2.8 million is for 6 months of the upcoming biennium. And lastly, $12.7 million for enhancements within the uniform dental plan. This $12.7 million reflects 18 months of funding for the upcoming biennium. And if we move to the next slide, I'll go ahead and explain what that $12.7 million is. So you'll probably remember, since I've mentioned it in each of my previous presentations, that HCA submitted a request for funding that included a variety of options for dental enhancements. The items in the far right column with a check mark are the items that total up to the $12.7 million on the previous slide. I did want to include, though, the full set of options that we did request here so we can be very clear on which items were included in that 12.7. So composite coverage for posterior teeth fillings, as well as eliminating the deductible for children up to age 15, increasing crown coverage up to 70%, as well as increasing the TMJ annual and lifetime benefits were included in our final conference budget funding. The combination of the Uniform Medical Plan Diabetes Management Program, the Vision Enhancement, and the Uniform Dental Plan enhancements do satisfy the terms of the collective bargaining agreement and the additional investment made within that agreement. On the last slide are two new items. The first one, I believe I presented on last month, which is a proviso for $324,000 for the implementation of the substitute Senate Bill 5275, which Cade just walked through, which would expand access to SEBB benefits through employer group contracts. And the last one here is new since I spoke to you last, which is starting in July, as the public health emergency comes to an end and federal requirements for carriers to provide over-the-counter COVID tests are ending, the final conference budget included language that will allow for Uniform Medical Plan to continue to cover 2 test kits per member per month with no cost share. And I will stop there for any questions since that was my last slide.
Any questions from the board? Seeing none. Thank you, Tanya.
All right, thank you.
All right, next agenda item is Janice McAlpin, Senior Account Manager with Employees and Retirees Benefits Division, and Sarah Whitley, Finance Manager from FSD, are going to provide us with some more information regarding UMP's hearing instruments benefit and introduce a proposed resolution to implement a bill from this past session. Materials behind tab number 6. Hey, folks.
Good morning, Chair McDermott and members of the board. For the record, my name is Janice McAlpin.
Oh, excuse me. And my name is Sarah Whitley. I am the IRB Finance Unit Manager here at HCA.
And we will be co-presenting on UMP hearing instruments today. So prior to plan year 2021, the UMP hearing allowance for hearing instruments was a total of $800 every 3 years for either 1 or 2 aids. That means that a member was provided reimbursement for up to $800 for hearing instruments every 3 years, and so any costs above that $800 were the member's out-of-pocket responsibility. Based on what we know about the average cost of a hearing instrument prior to 2021, most members obtaining hearing instruments were paying significant amounts out of pocket, suggesting that the $800 benefit was not set at a sufficient coverage level. During the 2017-2018 legislative session, SB 5179 passed and required coverage of hearing instruments every 5 years for PEB and SEB employees and dependents. This legislation resulted in the current benefit coverage levels for hearing instruments in UMP, which effectively provides coverage at $0 member cost share for up to 1 instrument per year every 5 years. And we will go into the next slide to talk about the past legislation from this year, which is HB 1222. So here's an overview of House Bill 1222, which has passed legislature and is awaiting signature on the governor's desk. So what this entails is that the current law will expire as of December 31st, 2023, and this will make House Bill 1222 effective January 1st, 2024. It impacts the general large group commercial market health plans, which includes employees and dependents of all PEB and SEB program plans. It requires coverage for hearing instruments, which excludes over-the-counter hearing instruments, at no less than $3,000 per year with hearing loss every 36 months. And this is not subject to the enrollee's deductible unless a plan is offered as a qualifying health plan for a health savings account, which for SEB UMP, which would be our UMP high deductible plan. Going into the next slide, we will look at OTC, which is over-the-counter hearing instruments specifically. This is a federal rule from the U.S. Food and Drug Administration, FDA, and this was implemented effective last October 17th, 2022. So the FDA established a regulatory category for OTC hearing aids to improve access for hearing aid technology in some instances. So OTC hearing aids are only intended to address perceived mild to moderate hearing loss in people aged 18 or older. And so this enables consumers, again, with that perceived mild to moderate hearing impairment to purchase hearing aids directly from stores or online retailers without the need for a medical exam, prescription, or a fitting adjustment by an audiologist. And so for hearing aids that do not meet the requirements for the OTC category, so for example, because they are intended for severe hearing impairment or users younger than age 18, are prescription devices. And we'll go into, on the next slide, a comparison between OTC and prescription hearing instruments. So starting on that top row for selection process, the main difference in selection process for OTC is that OTC allows a self-selection, while prescription requires an assessment from an audiologist or a hearing instrument specialist. Moving down to that next row for fit specifics, prescription hearing instruments again require a licensed audiologist or specialist, while OTC allows for self-fitting. And moving down to the last line for hearing loss diagnosis and severity, that's required to be diagnosed by hearing aid exam and assessment. OTC, again, it allows and is only intended for self-perceived mild to moderate hearing loss. Going on to the next slide, there's a couple more categories to go over. On the design line, OTC hearing instruments are intended as a one-size-fits-all, whereas prescription hearing instruments are customized to the member. Amplification levels are for both OTC and prescription hearing instruments. Those can be verified by a licensed audiologist, but again, it's not required for OTC. And now on the next slide, I'll give you a few examples of what the top-ranked OTC hearing instruments in 2023 are. Looking at that top line with the different categories, the table differentiates between two battery options, one being a standard battery-operated model or if it has a rechargeable battery, whether or not the OTC hearing instrument is Bluetooth compatible. Moving to the right, what is the length of the warranty, how many model options are available for selection, and then on the far right column, what is the price of the OTC pair. You can see that the more expensive option 1 at the top of the table mainly includes 2 battery options, Bluetooth capability, and a longer warranty. Now moving on to the next slide to cover what is actually available in the SEB program as of today. On the left-hand side, you can see our different carriers, our different health plans, and on the far right side, you can see, do they cover OTCs? For plan year 2023 in the SEB program, there is a mix of coverage. Kaiser Permanente does not cover OTCs, whereas Primera and UMP plans would cover OTCs if it met the plan limitations. There are no intended coverages on OTC for plan year 2024, even with the passed legislation of House Bill 1222. It does not mandate OTC coverage. And as I just referenced a moment ago, Primera and UMP are noted as OTCs being covered under plan limitations, while the federal rule is intended to allow members to purchase hearing instruments without the need of a hearing exam or prescription or a fitting adjustment by an audiologist if the member were to meet plan specifics, such as the purchase of a hearing instrument prescribed as a result of an exam and shows that it's necessary to treat hearing loss, it would be covered. And moving on to the next slide, I'll hand it over to Sarah.
Yeah, thank you, Janice. For the record, Sarah Whitley here. At our meeting in March, we brought you a few slides that featured claims data that really supported our discussion around how changes in hearing aid utilization and unit cost were identified as a possible area of focus in UMP. And our March presentation included data for claims incurred and paid through September of plan year 2022, which only provided partial insight into the 2022 plan year utilization. Since that meeting, we've received another 3 months of data with claims for services that were incurred and paid through December of 2022, and we've brought an update back to you this month because we believe this information and additional data helps give us a more accurate picture of what we're seeing for hearing aid utilization in plan year 2022. It is important to note that we don't consider data reliably complete until we allow for processing of claims through at least March of the following plan year, so that would be March of 2023. So the results for 2022 that you see here today cannot yet be considered final and may increase once we have full runout for these completed claims. So again, this slide here is organized by the two key drivers that we brought to you in March: utilization on the left-hand side of the slide and unit cost on the right. The bar graph on the left-hand side of the slide here shows the distinct count of members with a hearing aid paid in each plan year. So the lime green bar here is experience for the PEB Medicare risk pool. The bright blue bar is PEB non-Medicare, and the gray blue bar is SEB UMP member experience. So it's clear that while we're seeing some dampened experience when compared to plan year 2021, we're still observing much higher than average historical utilization of hearing aid benefits into plan year 2022 with this additional runout of data. Moving to the right-hand side of the slide here, the patterns observed in large unit cost increases beginning in plan year 2021 persist into plan year 2022. The table on the right here shows that on average across all programs and risk pools in UMP, we're paying approximately $5,700 per distinct member with a claim in plan year 2021, and approximately $5,800 per distinct member who had a claim for hearing aids in plan year 2022. So it's important to remember that an average is of course calculated as the total UMP paid amount, so the sum of all claims divided by the distinct count of members who received a claim in that plan year. And given the nature of an average, we wanted to include a sense of what claims are contributing to the higher bounds of that average calculation. So the second row featured in this table includes the maximum UMP paid claim amounts across all plan years. In 2022, we're seeing hearing aid claims paid as high as about $20,000 per distinct member, and in 2021, the maximum paid amount was around $17,000. Moving into our next slide here. So this slide features the total UMP plan paid amounts for hearing aids, again by program and risk pool. And again, with that additional 3 months of data, we're seeing a similar pattern observed in plan year 2021 persist through December of plan year 2022, with much higher than historical annual paid claim amounts for this benefit being driven both by what we just talked about on the previous slide, increases in utilization and unit cost of hearing instruments in UMP. And again, I want to remind the board that with additional time for claims to fully complete, we do expect the 2022 numbers to increase slightly. The data presented today for 2022, while it includes claims incurred and paid through December, cannot be considered fully complete just yet. So our next slide here also includes an updated graphic from our meeting in March, and it provides a more granular level breakdown of UMP paid amounts, this time by cost range per hearing aid claim, and has been updated to reflect the 2022 plan year experience. In March, I believe this graphic included 2021 year experience. Each bar, again representing program and risk pool, provides a count of distinct members with a claim for hearing instruments that fell within that cost range during the 2022 plan year. And again, the story continues. A very similar pattern persists with significant variation in UMP paid amounts by member with a claim. The buckets include the count of members with a paid claim in each cost range and vary from that lower range listed at the top of between $0 and $4,000 per member claim to claims greater than $9,000 at the bottom of the slide here. So that brings us to our next slide here, which gives us kind of a summary of the insights that we were able to glean from the data. And me being the data nerd, my favorite part about crunching numbers and finding patterns is really uncovering the underlying theme that helps us guide our decisions that are really rooted in that data-driven decision making. So the 2021 and 2022 plan year data tells us that about 80% of members who had a hearing aid claim in plan year 2022, here is what we have on the slide, received 2 hearing aids. So overwhelmingly, our members are receiving 2 hearing aids, with only about 20% receiving 1 aid. And with that context, connecting that data point with what we know about the average paid per distinct member, we see that UMP is paying on average about $6,000 per distinct member across the 2 plan years. We can therefore conclude that on average, UMP is paying approximately $3,000 per aid for all members across the PEB and SEB programs. And given these insights, the plan year experience for years 21 and 22 support that a $3,000 per ear coverage resulting from House Bill 1222 would maintain a sufficient and valuable hearing instrument benefit. Not only that, but from a cost containment perspective, given that unit cost is a key driver of the significant increases in UMP paid dollars for plan year 21 and 22, the results of House Bill 1222 are also assumed to place downward pressure on our member premiums for both Medicare and non-Medicare UMP members across both PEB and SEB programs. To take that one step further, our next slide here provides some assumed outcomes of House Bill 2022. We've analyzed the assumed outcomes of the legislation, and had this been in place in plan year 2021, UMP claims liability would have been approximately $6 million lower. As a self-insured plan offering, UMP premiums for members are established based on the assumed projected costs to cover the healthcare claims incurred by members in the plan. And if healthcare cost liability increases, upward pressure is placed on those member premiums to cover the cost of that projected increased liability. And vice versa, right? As a healthcare cost liability in UMP is assumed to decrease, downward pressure is placed on premiums. And again, given the assumption that cost liability will decrease in UMP as a result of House Bill 1222, and assuming similar levels of utilization into the future, a $3,000 per ear hearing instrument is assumed to place downward pressure on our members' premium across both the PEB and SEB programs, while also maintaining access to a quality and essential health benefit for our members. Furthermore, when we spoke to you in March, we mentioned that the current benefit provides a lack of incentive for both members and providers to avoid really high-cost instruments that might not be medically necessary. The benefit levels resulting from House Bill 1222 should lead providers to steering members toward lower cost, but still high-quality medically necessary options. And it's important to note that if members want to select a still higher-end hearing instrument with some of the bells and whistles that might not be medically necessary, they can still do that, but they must pay the difference between the health plan coverage and the cost of that item out of pocket. Janice, do you want to take us into the final slides?
Thank you, Sarah. So now you've heard from me what the previous coverage was back to prior to 2021, what the current coverage is for UMP, and what HB 1222 would make effective January 1st, 2024. And you've heard from Sarah the data to support that. Now in front of you is a proposed resolution for your review. This will be voted on at the June 1st board meeting. But the proposed resolution for SEB 2023-05 is beginning January 1st, 2024, prescribed hearing instruments in all uniform medical plans will be covered up to $3,000 per year with hearing loss at least every 36 months without member cost share. Coverage for members enrolled in UMP Achieve 1, UMP Achieve 2, and UMP Plus are not subject to the member meeting the plan deductible. And coverage for members enrolled in UMP High Deductible are subject to the member meeting the plan deductible. Going into the next slide, I'll give you a few examples of what that would mean for implementation. So in the first bullet point, it talks about a current UMP member purchasing a set of hearing aids in December of this year. Under the proposed resolution, that would mean the member would be able to purchase a new set of hearing aids as soon as January 1st, 2024. On the next example, a UMP member purchases a set of hearing aids in January 2024. That would be under House Bill 1222 coverage. And under that proposed resolution, the member would then again be able to purchase a new set of hearing aids as soon as January 1st, 2027, at least 36 months later. And under the last bullet, under the proposed resolution 2023-05, UMP will continue to provide reimbursement for OTC hearing instruments if hearing exam and prescription requirements are met. And going into the next slide, I'll cover one quick thing before taking any questions. As next steps, we will send out the proposed policy resolution to our stakeholders for feedback tomorrow. That will go out tomorrow, Friday. And for members of the public who wish to provide comments regarding the proposed policy resolution, they can submit feedback by May 15th. and that will go to the HCA PEB SEB Board Policy Feedback at HCA.WA.gov. And we will bring the recommended proposed policy resolution to the board for action at the June 1st board meeting.
Thank you. I do have a question on the over-the-counter hearing aids. Are we able to use FSA and HSA dollars to pay for that?
Yes, I believe so. It just wouldn't be covered under the UMP medical benefit.
Right.
Yeah.
Let's make sure we know that.
Yeah. We'll bring that back and confirm
Okay.
that.
Do we have questions from the board? Donna?
Yeah, the proposal is UMP, and all the examples are UMP. How does this affect Primera and Kaiser?
That will be part of one of the upcoming board presentations for it was only specific to UMP today, so we can take that back and bring that up to the board.
So Donna, is a more fair question, what is the benefit design of those other plans? Because we can't set their design. So you want to know how they're covering hearing aids?
Well, I know what Kaiser is. Kaiser is the same as it's zero out of pocket every 5 years.
Okay, so you need Primera.
And I don't know Primera,
Okay.
but I know that with this law changing, Kaiser could come back with the same type of proposition during negotiations, correct?
Yes, that is correct, Donna. And as Janice mentioned, we will be bringing more information on that in subsequent meetings. Part of the reason why we brought the UMP information today is that it does impact rate setting, and so we wanted to make sure that that it was included in the June rate setting.
Thank you.
Any other questions from board members? All right, Janice, Sarah, thank you. We're up for public comment. Is there anyone on Zoom that would like to provide comment? If so, please put your hand up and we will gather your names and make sure everyone who wants to talk has an opportunity. We're taking notes right now. So one sec. Is that the only one? Okay, we see one hand. Fred Yancey, would you like to present your comments?
Yes, I would. Thank you. Good morning, I guess. I have sent a letter to the board and, of course, to the two presenters regarding some concerns I have with this hearing aid issue. And if I understood correctly, there's also a site on the, you gave a very long email address to send comments on this proposed policy, and if you could send it to me or post it, so I could write it down. I appreciate it. It was way too fast.
Can we post that on the in the chat? Can we do that?
The time to read the letter where I outline my concerns. It's important to understand that the law that was passed said that no less than 3,000, didn't mandate that no more than 3,000. That's a decision that the healthcare authority has made. And my question to you, just leave this, is, I understand clearly that logic would seem to indicate that that there would be a downward pressure on premiums as a result of, a cost containment system being put in place. I would be interested to know what historical evidence there is that indeed that has happened in the past, anytime you have made efforts to contain the cost of the outlay for any sort of services. I'd be interested in what sort of history that proves that assumption to be true. I tend to think the premiums are going to go up regardless of claims history, but I'd be interested to see proof of that assertion. I will leave it at that. Again, my name is Fred Yancey, speaking on behalf of the school retirees and mostly medical retirees in the Fred Zone. And I would encourage the board to look at the numbers of people that that use hearing aids in excess of 6,000. It's almost close to 50% of the users, and that might be a little on the high side, but you are affecting, the quality, the choice that the people have in choosing hearing aids by, should you wish to adopt this law. Anyway, thank you very much for your time, and thank you all for your service on the board. It is a very complex system that you find out every meeting. At least I find that. Thank you.
Thank you for your comments, Fred, and we will send you that email address for comment. And I also wanted to acknowledge that we had received Fred's comment, and as Janice mentioned, we will be bringing the other public comment to the next board meeting.
Do we have any additional members from the public who would like to comment? All right, not seeing any. We don't have any in the room. Our next meeting is going to be June 1st, 2023 from 9 to 1:30 with the same format of attendance in person or via Zoom. Jean, any final comments for today?
Yes, so I know the board appreciates a preview of a few of the potential topics for the next meeting, and assuming that HB 1222 is signed by the governor, we will be bringing the board a vote on the UNP hearing instrument benefit. And we also will be having our first executive session of the board as we shift into the 2024 rate negotiation process. Dave and I would like to encourage the board members to attend the June 1st meeting in person, if at all possible, for this particular executive session. That's it.
All right, any final comments or thoughts from the board? Seeing none, this meeting is adjourned. Thank you. Folks, thanks for making this excellent. I know the hybrid is kind of a tough scene, but you guys did awesome. Appreciate it. Thank you.